I'm Dr. Flo Barber Hancock, Director of Hancock Craniosomatic Institute. I'm delighted to introduce this exciting new paradigm, craniosomatics. This demonstration by Dr. Hancock shows how our unique cranial therapy techniques can change muscle function and can produce long-term relief of chronic pain. The typical human body is asymmetrical in both structure and function. It is significantly compromised by the common presence of two chronic patterns, a right torsion and a left lateral strain. These cranial patterns appear to be present at birth, although they become more apparent when we become weight-bearing. The combination of these two cranial patterns results in tipping of the sacral base to the right with rotation in the horizontal plane, and also a slight compensatory spinal scoliosis with four opposing curves. One of the most common diagnostic findings associated with these patterns is a functional imbalance in many paired muscles, as Dr. Hancock will soon demonstrate using manual muscle testing. The presence of the right torsion and left lateral strain may be the etiological basis of Dr. Carver's The Typical, as described by Beatty and others, and the Sacro Occipital Technique, SOT categories 1, 2, and 3, described by Dr. Dejeanette. Also, the Common Compensatory Pattern, described by Drs. Zink and Lawson. Chiropractors and osteopaths use a variety of treatment modalities to treat craniosacral, postural, spinal, and musculoskeletal problems. However, manual muscle testing and other evaluation techniques from applied kinesiology demonstrate that the chronic right torsion and the chronic left lateral strain patterns and their associated compensatory neuromusculoskeletal patterns are still present in both the general population and the clinical population. These findings indicate that the treatment techniques currently in use aren't really eliminating these chronic patterns. Dr. Hancock drew on his multidisciplinary background, many years of clinical experience, and extensive studies to develop effective treatment procedures. He was able to create a protocol of special cranial treatment procedures that effectively release the cranial torsion and soft tissue holding elements. And this restores mobility and alignment to the osseous cranial structures. The craniostructural integration protocol developed by Dr. Hancock allows the cranial bones to move more freely and reduces tension in important muscles of the neck. The balance mechanisms of the cranium are also able to work more effectively, so improvements in muscle function, posture, and balance are maintained as long-term corrections. Dr. Hancock has been using and teaching these breakthrough cranial techniques for almost 30 years in the US and internationally. In this short video, he demonstrates neuromusculoskeletal imbalances, his craniostructural integration approach that releases the chronic right torsion and left lateral strain, and some of the changes in muscle function that are immediately evident. Here's Dr. Hancock.
So this is Lori. She's agreed to be our model for this demonstration. Thank you, Lori. So what we're looking at is general posture for this type of pattern. I'll run down this. So right now, Lori has a high left ear. She has a high left shoulder. If we palpate the iliac crest, she's high on the left side, relative to the right, or low on the right, if you want to put it that way. And if we check posterior superior iliac spines here, she's low on the left, high on the right. If we come down here and we check if we palpate the glutes to see which one is most flaccid, the left one is firm, the right one we seem way in on. So this is firmer, more flaccid over here. if we look at the gastrocs down here, this one is rounded, foot is facing forward. Over on this side, this one, the gastroc is almost always more posterior on the lateral portion, and foot is generally turned out. So certainly when Lori's lying down, you'll see that. So in doing a prone evaluation, here again, we're looking at what's happening with the gastrocs. This one is rounded. This one peaks up on the laterally out here. If we check the leg links by the internal malleoli, or just looking at the heels, the right leg is functionally shorter than the left. If we check the Achilles tension here, we have plenty of give over here. And when we come over to the right side, really restricted. So right side's restricted, left side is nice and flaccid. I'm going to check the shoulder and hip extensor muscles. So coming over to the left side over here, hold this up, resist when I push down. This is strong on the left shoulder extensor. I'm going to check the left glute max, so bring leg up in the air, hold this up. Left glute max is strong. That's hip extensor down here, extensor group. If I check the right side, the one with the tension in the Achilles tendon here, bring leg up in the air, hold tight, we'll see that this one, hold, doesn't work. It is inhibited, and bring the arm back over here. We're going to check the right extensor, shoulder extensor muscles, hold. These are also compromised and inhibited. So we have the right shoulder and hip extensors, which are weak. Left shoulder and hip are strong, means they're facilitated. So it's just a facilitation inhibition pattern going on there. So let me have you turn over on your back. So in the supine position, we're going to start off by checking the shoulder and hip flexor muscles, the flexor groups. So we'll start with the right shoulder flexor groups. Hold tight. Note that this arm locks in place nicely. It's strong. If we check the leg down here, the right hip flexors, hold. They're also strong. If we go over to the left side, hold. Now suddenly we'll find that the hip and shoulder flexors on the left side don't work. They're inhibited, they're weak. This is characteristic of a right torsion pattern. Starting off years ago in teaching kinesiology for Touch for Health Foundation, 1975 I became an instructor. I used to incorporate other tests in here, such as eye movement patterns, jaw movement patterns, and so and so. So over the years I found that these can determine, to identify the patterns. So if we go back and we take any strong muscle, hold tight, and I have her open her mouth, open mouth wide, it wipes out any strong muscle. Open mouth. Wipes out any strong muscle. That's because there's a rotation of the innominants here, and that results also in a rotation then of the temporal bones. So there's an imbalance in the temporal bones. So if she tries to open the mouth, then any strong muscle is going to weaken. What we're going to see is that she can shift her jaw to the left, and any strong muscle stays strong, but she can't shift jaw to the right. She can look to the left, but she can't look to the right. So demonstrate that. Hold this up. That's strong. Shift jaw to the left. Doesn't care. Hold tight. Doesn't care. Shift jaw to the right. Doesn't like that at all. Look to the left. Doesn't care. Look to the right. Doesn't like that at all. I can also go up here and check the rest of the recti muscles. Look to the left. And what we're going to find is look to the right. Top of your head, towards your feet, straight ahead. So if we cover up one eye, generally we have any movement, left, right, up, superior, inferior, or even straight ahead, weakens a strong muscle. Cover up the left eye, look to the left, to the right, top of your head, towards your feet, look straight ahead. Okay, so she weakens in all positions here. I check this because this is going to, since this is what I always find, if I don't find it, then this is telling me that something else is locked up in the sphenoid. And so it's, you know, I should be prepared to find something else. We can also, for those people who like to adjust the upper cervical, if I go to the upper cervical on the right side and just touch it, hold tight, which is therapy localization, she's strong. If I push it medial, we'll see that it immediately wipes out the arm. There's also a problem with the 5th and 6th cervical. So if I go down, number 2, hold, number 3, number 4, but when I hit number 5, arm goes down, number 6, arm goes down, number 7, hold tight. Generally can hold number 7. There's a rotation of the rib cage coming through here. So we're going to find the same thing with the 5th rib. So hold tight, that's number 1. That's number 2. That's number 3. That's number 4. And when I hit number 5, you'll see the arm goes down, hold tight, and number 6, and then it straightens back out again. So this is all because of the rotation back and forth. If we try checking muscles, what we'll find is that all paired muscles are imbalanced. So if I take the latissimus dorsi over here on the right side, hold this tight to your side, she's strong. If I take the one on the left side, forget it. If I go up to the clavicular portion of the pec, thumb down, I'm going straight lateral, hold tight. But the sternal division is fine. Hold, I'm pushing up. Sternal is strong. The clavicular division is weak. And if we go to the other side over here, we're going to find just the opposite thing, pushing lateral. That's the clavicular division is strong. The sternal division, forget it. If we go down here and we check well, tensile fascia lata, psoas, and some of those, what we're going to find is over here on the left side, turn foot in. TFL is strong. On the right side, TFL doesn't work. If we check the psoas, we're going to find the psoas works. It doesn't work on the left side here. Hold tight. That's weak. But it's strong over here on the right side. Hold tight. It's strong. So at any rate, major things here. The abdominals don't work on the left over here. We can use therapy localization there. If this arm is strong and I touch the abdominal recti on the right side, arm stays strong. If I go across the boundary there into the other side, she doesn't work. So the abdominals over here don't seem to be working very well. And piriformis muscle, bend leg. Hold this, I'm going to pull a foot toward me. Piriformis on the right side doesn't work. Piriformis on the left side, hold tight. It's strong. So we could go up all paired muscle groups. We're generally going to find there's an imbalance going on there. Anyway, the torsion pattern is going to wipe out all alternate muscle groups. We know it's a torsion. If I take these blocks, and we could call it category 2, bend your right leg, roll up. If I put a block under the crest of the ilii on the nominal on the right side, going straight across, drop leg. Then left leg. If I put this under the femur head, drop leg. In about a minute's time, all these patterns we had before will be gone. So let's just use a strong arm over here. I mean, this one was weak before. Hold tight. Okay, so this one is now strong. The leg would be strong down here too, but let's go back to the eye test. Hold this up. Hold tight. I'll stay with the anterior deltoid. Look to the right. Doesn't care anymore. Look to the left. Doesn't care. Never did on that one. Shift jaw to the right. Doesn't care. Open your mouth wide. doesn't care. And if I cover up one eye, look to the left, to the right, top of your head, towards your feet, straight ahead. So all the patterns that we had before immediately clear when we block the pelvis. So fine, we have a category 2, right category 2. For a few years after I graduated from chiropractic college and was in practice, I went down and checked everything, and everything seemed to be fine. We got it. But then one day I made the mistake of saying, would you come up? Would you come up and walk across the room over there and come back? Actually, that's far enough. That's far enough. Back on the back again. Problem is that immediately after they get weight bearing, then everything goes right back out again. Hold tight. So obviously, straighten leg, straighten leg. Hold. So we're back to being strong on the right, weak on the left. So I tried blocking it repeatedly 4 or 5 times, but if I couldn't get her to hold to walk across the room and come back, then with anything I knew of there, then obviously she didn't make the front desk either. So I went down and studied osteopathic cranial sacro with the Upledger Foundation in West Palm Beach, and then I found that 5 grams of force didn't touch it. I was convinced that the problem was still a right torsion, because in Harold Magoon's book, Osteopathy in the Cranial Field, on page 74, he says, spinal scoliosis and cranial scoliosis are inseparable. What is not generally realized is that the cranial abnormality precedes and dictates the spinal pattern in a good proportion of the cases. So, and he shows a picture of a scoliosis, and the scoliosis in the cranium would be a torsion. Convinced that he was correct, and in osteopathic literature they're saying that there's a sacral tippage on the right, occiput tipped on the right, and in a right torsion. And that seemed to be consistent with what I had. I went back and developed some techniques to release the right torsion. And we palpate the cranium over here. Occiput controlled by the bottom hand, down here is sphenoid by the top one. So if I take the cranium into a right torsion, I'm putting, instead of 5 grams of force, I'm probably using a pound, maybe a pound and a half, probably a pound, but anyway, a little bit more than that. It's moving into right torsion, moving into right torsion, moving into right torsion. Okay, that's the end of it. If I let up and I try to go into left torsion, it doesn't go into left torsion at all. So that would confirm that the cranial pattern is a right torsion. Now, the sphenobascular junction is long since fused here, so what we're looking at here is that all the bones of the skull have moved into the pattern of a right torsion. The holding elements on all these bones, the sutural ligaments and the falx cerebri and everything else, have also distorted into right torsion. So in order to get rid of the pattern, what I had to do is go back and restore mobility back into left torsion. And like I say, 5 grams of force didn't do it. So I found that if I went back and I freed up the lambdoidal suture, and I used a different hand hole. So instead of using a frontal occipital hole here, I'm turning this around like this, and now I can lock in, I can take it into left torsion as far as it'll go, and while I'm holding it there, I'm going to take it into other patterns. Nothing else. So that's the end of it. That's all I'm going to get. But I have considerable more motion over here in the left torsion. In fact, I may have more motion in the left torsion now than right torsion. That means I've changed the holding elements in the skull. So that part's done. Let me have you come up, walk across the room. So before, it wasn't stable enough to hold the walk across the room. So let's increase it a little. Jog over across the room and back into the kitchen and back. Okay, so let's have you face down again. Face down. So now when we go back and we look at this, we find that the legs are internal malleoli. This is basically even now. If I check the tension in here, the tension's gone on the right and then right side. If I palpate the glutes, these feel about the same. We started off with the left extensors being strong. Bring the leg up in the air, hold it up. They're still strong. Hold. But what we find now is the right extensors are also strong. Come up in the air, hold this up. That's just an arm over here. Hold tight. Okay. So what does she have to get this to come out? I don't know. Sometimes I don't see patients for years, and the pattern is still clear. Let me have you over on your back. So we'll remember over here that when we flipped Laurie over, hold. We were strong on the right side. Hold. Straight leg. But we were weak on the left side. Hold. But not anymore. Hold tight. And now if we take any strong muscle, hold it up. Open your mouth wide. It doesn't give a hoot. Look to the right. It doesn't care. Shift jaw to the right. Doesn't care. If we cover one eye, look to the left. Doesn't care. Right. No. Top of your head. No. Down toward your feet. No. Straight ahead. No. These are all strong now. Okay. So are we totally out of the woods? No. There are two basic patterns here that distort the body, as I mentioned earlier. One of them is a right torsion. The other one is a left lateral strain. The left lateral strain is also a typical of the pelvis. It's also a counter rotation for opposing curves. But the osteopaths say, well, if the pelvis is rotated to the right down here, so I can rotate this to the right, but I can't rotate it to the left. Let me just show you this. Hold. I can't push this left, I can touch the left shoulder. If there was a problem with just touching the shoulder, it would be therapy localization, but it doesn't care. I can't push this posterior toward the table. I can't push the innominate posterior toward the table. I can push the rib cage towards the table, but I can't lift it back up. That's the rotation back and forth. If I come down to the first rib down here, I've got a problem here. And if I come up here, the cervicals up here, if I turn it, this upper cervicals this way versus this way, we have more and better movement to the left. So in the osteopathic literature, there's a pattern described by Zink as a common compensatory pattern. Upper cervicals have moved to the left. He's showing us as diagonal lines, but really the left shoulder is moved to the right, the rib cage is moved back to the left innominate is moved to the right. If we check vertebra, hold tight, hold it up. And I'm going to take any cervical vertebra and I will pull it toward me and see what happens. Hold. When I pull it toward me, nothing happens. If I go to the next one, we'll see the arm goes down. If I go to the next one, hold, it's strong. If we go to the next one, arm goes down. It's sort of like each vertebra is rotated relative to the other. If we take the soft tissue on this side of the body and I push it toward the feet, it doesn't care. Don't push it upward. It doesn't want anything to do with going up. Therefore, there's a problem with the TMJ right here. I can't twist it that way. I can't bring it this way. The whole side of the head doesn't want to go up. And on this side, it doesn't want to come down. So that's a left lateral strain, preventing some of the torsion patterns from coming out. It's still maintaining the low cervicals down here. Oh, I still have a problem there. I still have a problem over here in the abdominal region here. I still have a weak left psoas, right when it's fine, and I still have a weak right TFL over here. Oh, turn foot in, hold. TFL, strong. Psoas is weak over here on the left. Hold this up. Those are really parts of the torsion. but that's because the torsion and the left lateral strain were functioning together there. I can't get the rest of the torsion out until I get the lateral strain out. Okay, back on your back. Patterns that we had before were in part that I couldn't push cephalad on the left side, caudal on the right side. The jaw has changed there. That's changed. I can push down on the shoulder now. It doesn't care. And down on his hip, it doesn't care. I can lift the right shoulder. It doesn't care. Lift the right hip. It doesn't care. So all the indicators I had before are gone. How long does this last? It may last for months. I can't put her back in distortion.
Thanks for watching. More information is available on our websites, www.hancockclinic.com and www.craniosomatics.com. The full-length version of this video is available for our students to purchase.